Hi everyone, my name is Abdul Rehman and I am a neuroscientist. And today we will be discussing about schizophrenia, psychosis, its causes, and all the underlying biomarkers and its neurophysiology and pharmacology. And for that, we have a very senior and expert on that, Dr. Erik Messamore. Dr. Erik Messamore is currently working in Department of Psychiatry in Northeast Ohio Medical University. He did his PhD in pharmacology in Southern Illinois University and postdoctoral fellowship from Sweden. He did his MD from University of Illinois Chicago. He did his residency in psychiatry from Oregon Health and Sciences University Portland. He also holds the license of State Medical Board of Ohio and Oregon Board of Medical Examinations. And he also holds the board certification of National Board of Physicians and Surgeons, American Board of Psychiatry and Neurology. And he has a lot of publications as well. And thank you so much, Dr. Erik, for joining me today on the podcast.
Absolutely. My pleasure to be here.
So it's very fascinating and actually inspiring for me to see your academic background and that you did your PhD in pharmacology and then postdoctorate from Sweden. That's actually very interesting. But coming to the psychiatry, and it's totally different route, how come you went into that? What made you come into psychiatry after pharmacology? Because you were like opting for a totally different route of research that currently I'm doing. So, but you just went for psychiatry.
Yeah, well, that's a great question. And I would, on paper, it looks like I've done many different things, but in my mind, I've been doing pretty much the same thing, which is to try to solve important problems that people experience that are related to neuropsychiatric illness. So I first had, perhaps this is going to be useful for people who are in training. I would say to anybody who's in that situation, once you open one door, you'll find doors that you had no idea ever existed. So most courses in academics take unexpected turns. But I found myself interested in drugs and what drugs do, so I was studying those. And again, with the idea that I wanted to be able to make some meaningful impact into the lives of people that are suffering from neuropsychiatric illness. By the time I was into my postdoctoral research, I realized two things. One, I'd become an extreme expert on a very tiny area, a limited area of knowledge. So when it came to, say, cholinergic pharmacology related to dementia, I was at the top of the world game. But then my peer group at Karolinska Institute had a lot of physicians who knew a little bit about a lot of things, and so I would learn from these colleagues that things that were facets of pathophysiology relevant to other illnesses actually were useful in my understanding of human brain illness. There was that, plus the frustration that it's easy to do studies in animals, but you can't really adequately model illness in humans when you don't fundamentally understand the illness in humans. So the attraction of learning broadly about human diseases, as well as being able to get more firsthand experience with people, drew me to medical school. So that's how I became a medical student. I still had the idea of becoming a neurologist or a neuropathologist, and I was it came as a surprise that I would like psychiatry as much as I did.
That's actually very interesting because, see, I'm going for that route of neuroscience and research and PhD, because it becomes very difficult once you complete your PhD, postdoctorate, and then again because it requires a lot of passion, I believe, and you're right that we get restricted to one domain while doing postdoctorate, and because physicians they have like an other broad domain to work with humans, because once you're doing like PhD or postdoctorate, you know that the experimentation, there are protocols that can be only performed in animals, right? So it gets kind of restricted, and I understand that you wanted to have a broader spectrum of all this research. So how about like as our topic is schizophrenia and psychosis, how would we define schizophrenia, or are they different terms or same terms, psychosis and schizophrenia?
Yeah, it's a great question, and I hear. I guess another one of the advantages of working as a physician is that I get to meet a lot of real people and know what kinds of questions
Mm-hmm.
people commonly have, and from my talking with large numbers of people, I think there's a tremendous amount of confusion around the terms psychosis and schizophrenia.
Mm-hmm.
It's a common misperception that psychosis. Many people think that psychosis is the same as schizophrenia. So, and both are antique medical terms. They were coined in the 19th century. So they're both due for an update. And I guess we'll use this opportunity now for an explanation. So psychosis, since I talked about coining words of the 19th century, let's start from the origin of the word.
Mm-hmm.
Osis is a medical suffix that denotes abnormality without evidence of inflammation. And in the 19th century, when medicine, the attention of the medical field was turned toward illnesses that affect mood, thought, or behavior. This was when germs were discovered, and we had microscopes, and it seems to me from reading about the era that it was a very ambitious time where there was a feeling that we had unlocked the mysteries of illness, and it was mostly infection and inflammation. So in those days, in the 19th century, doctors that worked in institutions where mentally ill people were cared for they would bring out their microscopes and they would look for all sorts of evidence of inflammation or infectious disease to explain these phenomena, and they generally found none. So that's how we got osis, to denote the medical illness that was thought to be at the root of some changes of thought and behavior. And the psych part of psychosis comes from the Greek word psyche, which in the 19th century was very much the equivalent of 21st century meaning of mind. So mind and psyche are ancient terms. We've had these around for millennia. But in a medical or a scientific sense, when we say psyche, or in the 19th century, when we say mind in modern era, or in 19th century psyche, we talk technically about the parts of the brain and the functions of those parts that create a sense of awareness, of self-awareness, of a sense of having thoughts and knowing those thoughts, of linking to memories and emotions. So conscious experience, more or less. So psyche, or mind, or the faculties of brain that give rise to conscious experience is the root. So psychosis is, in 19th century thinking, a medical disease without inflammation that affects these higher level brain processes. And psychosis today largely reflects those ideas. We can certainly talk more about the mechanisms of those things, but psychosis is, broadly speaking, a set of illnesses or a set of conditions which can lead to disruptions of these higher level brain processes. And that's typically manifested in the form of unusual perceptions. They can range from having thoughts that feel so different to me or feel so powerfully strange to me that I don't think that they're my own. Or those altered perceptions can go all the way to just perceiving outright sensory inputs without external stimuli. So we call those hallucinations. And the other classic feature of psychosis is changes of beliefs. Oftentimes these beliefs to people who aren't having the experience seem odd or bizarre. Frequently these beliefs revolve around themes of vulnerability or suspiciousness or paranoia, or of having special insights or gifts or religiosity or a sense of inflated importance. So those are the general categories of beliefs, and those different beliefs associated with psychosis get the unfortunately stigmatizing name of delusions. So broadly speaking, psychosis is a set of psychosis is a symptom. It's a medical symptom that can have hundreds of causes. It revolves around misperceptions, and it can involve outright sensory misperceptions, which we call hallucinations, or perceptions, altered perceptions of the importance of events. And when we have clusters of these misperceptions, the conscious mind needs to make an explanation for those. And so essentially, psychosis revolves around misperceptions that happen when the brain processes information inefficiently.
So from all that detail you told us, it seems like it mostly revolves on perceptions, right? So there's an, as you said that you mentioned yourself, altered perceptions, right? So I've heard that a lot and read about that as well, but I actually don't know how would it look like in real life. What would be the symptoms, right? Because you obviously have your clients, your patients. So how would actually in real life the symptoms of psychosis would manifest?
Sure. Well, I guess so. I have an illustration that I can show, and for people that are listening, I can narrate
Yep,
the elements of the illustration.
that would be great. Yep.
But before we get there, I wanted to impress upon people how much information your brain has to take in, and the extreme editing and editing of information that has to happen before it comes to conscious awareness. So if you understand this, you will see that there are just gazillions of opportunities for misperceptions. So people who study sensors, essentially, let me start you. Let me go. We'll call this Brain 101. Most all of a brain is devoted to sensing the environment, and the environment here is defined as the internal environment, things like stomach acidity, position of joints, tension of muscles, level of carbon dioxide in the blood, as well as the external environment, the temperature of the room, the sounds, the sights, the smells, the tastes, and estimates of how much information is coming from internal and external world are astounding. 11 million bits per second is the estimation of sensory input. And this is all generated in the form of electrical pulses, little blips of action potentials from each nerve cell. So the brain is bombarded with all this electrical information at 11 million bits per second. Estimates of how much information we can handle in our conscious awareness, in our mind or in our psyche, to use the older term, 50 bits per second. So we go from 11 million bits coming in to just about 50 bits per second that we can manage in our perception. So, and of course, that estimate is rough, but even if you want to give it a factor of 10 in Slack, so even if it's 500 bits per second, you're still against 1 million bits per second of incoming. So to manage this, there are lots of hardware and software hacks, I guess you would call them, that the brain employs. So information that can safely go in reflex arcs or in things that circumvent entirely conscious awareness are done so. For example, generally managing the CO2 level, the carbon dioxide level in your blood, we can do that without having to know. But if it does get to a critical level, there has to be a way that we can subjectively perceive that we should then move, change our environment, or respond at a gross behavioral level to do that. So a lot of information just gets out-routed to other systems. And of the stuff that the brain perceives as maybe significant for conscious awareness, it has to flag it. It has to somehow label a particular stimulus. For example, the sound of my voice as a lot more significant than perhaps the buzzing of the air conditioner unit outside, or the creaking of my chair, or the sound of my clothes rustling against my body. So all this information exists, and if I decide to pay attention to it, I'll notice it. But my brain usually locks into one thing and tries to drown out the other things. So those processes of eliminating information, of having to compile a bunch of raw information into sensory experiences like sight or sound, and of flagging information are the grand opportunities for misperception that can lead to psychosis. So let me then share a specific example of how that works in action. I'm going to show, for people watching on video, we'll see this scene. We're looking here at an office scene. This is, you're going to a doctor's office or a therapist's office. So you see the brain has to deal with a lot of information. And this is a greatly reduced number of stimuli, but we see in this visual image, we see the therapist with an extended arm pointing in the direction of a chair. We see also a table, we see some magazines on the table, we see a carpet, we see a curtain, we see windows, a plant, a desk, a garbage can, a computer screen, a clock, a wall with yellow color. There's even in this very simple drawing, there's a lot of information. So we need to, but before you could even know what was happening there, your brain locked on to a couple of things that it flagged as probably the most important.
Yep.
So we see in this second view of how the brain might perceive things, we see that a lot of the information, like the curtain, the wall, the carpet, is completely irrelevant, not even showing up in the preview of consciousness. And our brain has flagged the therapist greeting us and extending her arm, and we've also flagged the chair. So but by the time this reaches our awareness, we're seeing, I'm being invited into this office and I'm going to sit into the chair. That makes things easy, and that's what we say conventionally shared experience. Now let's imagine a scenario in which you're getting a lot of misperceptions of significance. So in this scene, we're looking at, again, a narrow view of possibly significant elements in the scene, but here it's a bit jumbled. Not only do we see the woman with the outstretched arm inviting me into her office, but we see in this example, the brain has flagged as equally relevant the clock on the wall. And that's immediately, to conscious mind, an unusual experience. Why is that this woman and this clock now so important? And we also have flagged in this example the plant and the garbage can. And so now if my awareness is saying that there's something about this that they are so important, but ordinarily they're not, I have to immediately come up with some explanation that does make sense. So let's try one. The woman and the clock, maybe this means that there is a sense, she's letting me know that time is limited, time is of the essence, time is ticking by. Plant and garbage can, maybe the plant is going to be disposed. Maybe this is symbolic for she is a messenger of impending doom for all life on earth. That would be, we could say a paranoid interpretation, or a suspicious or a anxious interpretation. We may also, depending upon baseline temperament and other psychological factors, we may think that the woman we can now see these connections that nobody else can see. That maybe the woman is letting us know that time is short. Maybe plants are the suggestion of life, and the garbage can means to get rid of all bad things. So maybe in this analysis, I have a special gift from God that lets me see that time is precious. Maybe I regard this woman as an angel. Maybe I see that preciousness is with life and that we shouldn't waste time on other things. So I can have, again, whether I have a suspicious or a paranoid interpretation or a religious sense of insight depends upon other factors, but they have revolved very much around the misperception of significant elements in this little scene. Now imagine if I have some disease process which is going on, which is causing my brain to flag as equally important the sound of my voice, the position of my chair, and the whirring of the fan of the air conditioning unit outside. I'm going to be consciously very bugged. I'm going to not feel satisfied unless I can come up with some explanation as to why these things that shouldn't ordinarily seem like they go together, how do they fit together? We have, as important as a drive for food or sexual reproduction or other sorts of things, we have an innate drive to construct a narrative of all these elements in our life, because that narrative allows us to make predictions about near-term future so that we can modify our behaviors toward maximizing our survival. When the flagging of significant elements goes wrong, that's the experience of the people with psychosis describe oftentimes. The world seems unusually full of meaning. There are all these messages that I'm trying to make sense of, and that the part that the brain makes sense out of them is getting unusual beliefs.
That was actually a wonderful explanation, but I have a question here. Is it specific to some kind of particular personality type people? Like I remember Carl Jung, he said he introduced some personality types. Like there was one, introverted sensors, right? So introverted sensors would have, because they have to retain, as you mentioned in the image before and your explanation, that they have to retain all much of the information, right, when they entered the room in that particular condition of psychosis, right, when it's manifesting. But introverted sensors do have a problem or a blessing, or which we call. What happens is when they enter a room or when they observe someone, when if the external stimuli are too much or there are too many things to observe, what happens is it's difficult for them to observe or retain a lot of information. So my question is, would it be very specific to such kind of people whose dominant personality type or cognitive function is introverted sensors, or it can be in anyone?
It can happen to anyone. So again, we're going to talk about we're talking about psychosis now as the medical or neurological symptom. There are so many opportunities for error in the brain, which is such a very busy thing. I think it's a fair analogy to say the brain is like a biological computer. The analogy holds on many levels. It takes information, it encodes information, it stores information, it retrieves information, and so forth. So valid enough. But unlike a computer, which is made out of crystallized silicon and metallic elements, which are stable across wide temperature ranges and any number of operating conditions, our biological computer is made of just cells, which are tiny and fragile living things. And they form these networks, which also are fragile and very sensitive to things like acid-base balance, sodium-potassium balance, level of oxygen, level of carbon dioxide, level of glucose. There are just a million ways to interfere with the system. And in our biological computer, this network has to function in a highly synchronized way with literally millisecond timing between events. And so you can easily see that a subtle change of pH perhaps changes the function of certain sorts of proteins on nerve cells, and that can delay the transmission of information by 5 milliseconds, 10 milliseconds, spread across a network that can have really outstanding effects to the detriment of the function of the system. So neurological illnesses are very common, and psychosis is very common because of that. But to the question of personality types, no, psychosis can happen to anybody, regardless of personality type. What the personality and past experience will influence is how the narrative one constructs around these unusual experiences. So for example, people who are have strongly religious backgrounds and are perhaps more trusting of unusual experiences, if they begin to have auditory hallucinations, may very easily interpret this as a religious experience. Whereas somebody who is maybe not so indoctrinated or acculturated to a religious tradition and is maybe a little bit more suspicious or guarded may have the same auditory hallucination and interpret this as something sinister. So it, how the experience of psychosis plays out is influenced by a lot of psychological factors, but the substrate is just a brain which can be very vulnerable. And speaking of the commonness of psychosis, I would just like to point out, I made a graphic for this one as well, just exactly how common psychosis is. And this, I think, illustrates the difficulty that the brain has, and how many opportunities exist for it to be disturbed. So here we're looking at studies of the annual incidence of psychosis in adolescents. So cases per year per 1,000 adolescents. So 75 cases per 1,000 is a reasonable estimate for the incidence of psychosis in teenagers. That is 3 times more likely than a teenager giving birth. That is 9 times more likely than a teenager getting diabetes type 1 or type 2. And it is 375 times more likely than a teen dying from suicide. So I find it interesting and sad that public awareness is good around we need to do things to prevent teen birth, we need to do things to prevent diabetes, and we need definitely to pay attention to suicidal risk factors. Yet psychosis is a much bigger problem than any of those three common things. That's why I call it the most common problem that nobody talks about.
Yeah, that's true.
And to
So,
that end, thanks for having me talk about it today.
so like, how does a person from, because we know that altered perceptions, right? So how does a person from altered perceptions move towards the process of having delusions or auditory hallucinations in
So yeah,
psychosis?
so the delusions I explained, that the delusions more or less represent the ideas or the beliefs that are constructed to explain things that seem significant that shouldn't, be together. So a way to explain all these perceptions. And there's a very good theory in the world of psychosis research called aberrant salience. And what I have described to you up to now is a plain language version of the aberrant salience hypothesis. And the aberrant salience hypothesis also attempts to, I think it does do a reasonable job of attempting to explain some of the features of hallucinations. And that goes as follows, that all of us have, the brain, in addition to being a gigantic sensory organ and perception generating machine, is also an idea generating machine. So, it generates constantly various ideas that largely are irrelevant and illogical and useless. And all of those things that are generated, illogical, irrelevant, or useless, we usually pay no attention to them. We're in conscious awareness at a certain age, you become very good at knowing which ideas are good and which ideas are so irrelevant that just let them go. So if you call it the chatter at the back of your head, or these sort of back of mind ideas, most of us don't pay attention to them. And also, I believe this is true. Sigmund Freud pointed out that a lot of those ideas are just rude. They have to do with aggression and sexuality and power and violence. As a psychiatrist, you can see enough people that have free access to those ideas that I can see where Freud got them. And I think it is part of human nature that we have in the back of our head all sorts of these more animalistic urges. Culture and society teach us to just put those aside. But what happens now if your salience machinery, or the parts of the brain that flag this is important, begin to pay attention to those back of the mind ideas that normally we never listen to, like I should have sex with that person, I should punch that person, or something like this. These are ideas, again, I want to emphasize for listeners, everybody has.
That's true.
And I want to emphasize this because a certain portion of the patients that I see hear those ideas and then they can't let them go. And so that I have, a so-called impure thought about, aggression or sexuality, becomes very difficult for some people. And the more you listen to them, the more hard they become to get rid of. And so then eventually some of them become my patient. And my colleagues in obsession disorders will oftentimes tell them, just sit with this idea for a while and you'll see that there's no danger that you ever act upon it. And then it takes away the power. But I digress, to come back to what happens though if the brain starts to flag those ideas as very important, but they seem so foreign to you. So you'll begin to perceive them as not mine, as coming from outside sources. So the idea of thought insertion is very common in psychosis. And I think that is because we're flagging as important and relevant ideas that are so foreign to the things that we want to think about, that we experience them as outside. And if that, you can turn up the volume on that and then perceive these as just external voices. So that does make sense. Another way to explain this is that the body has sensors on every internal and external surface. We have nerve endings that are designed to sense their environments and send little electrical signals up the chain to the brain, where all these individual bits have to be constructed in what we call sensory area, primary or secondary sensory association areas, to generate the perceptions of heat or touch or sound or taste or so forth. And functional brain imaging, EEG studies through fMRI, through PET scans, have shown us again and again that the primary sensory areas are not well regulated in people that have psychosis. So they either don't get the right inputs, and so they generate spontaneous messages without the right input, or they become overly active and can generate messages in that way. So you can have, again, sort of overactive sensory areas generating the perception of sound or taste spontaneously and erroneously. And when that happens, then again, that's another stimulus that the conscious mind has to make sense of. And so common ideas to make sense of these unusual sensory experiences are radios behind the walls, radios in my pillows, implants in my head that sort of tune into those messages, and things of those nature.
So, as you again mentioned about sensory perception, so can we say that like a person whose sensitivity towards towards the events, towards life, if it's more than any other individual, would he be suffering from some kind of more symptoms of psychosis?
So are you saying that people who just are more sensitive to, like...
Yeah, because when they receive too much external stimuli, right? And would they be suffering more from the symptoms of psychosis?
Well, what I hear you describing is applicable to a fairly large number of people in the world, who just are very sensitive and who have, say, a higher level of reaction to events, or thoughts, or gestures between humans, or emotions. There are different ways to describe this. I will call them, you can say, big feelers, or emotionally, or having higher levels of emotional reaction. And it is some people that have a very big ability to experience emotions, or to respond to things in the environment, oftentimes do get into a lot of psychological or psychiatric troubles from that. Typically, they become just flooded with intense... If it's happy, it's usually not a problem, unless the happiness leads to making decisions which are impulsive, and then those have secondary effects. But the experiences of, say, rejection, or of anger, or of sadness can be so intense that usually drives an effort to try to numb that, or to turn it down. So using drugs, or sex, or starting fights, or arguments, or drama are ways that are actually quite effective at changing the volume, or changing the nature of the relationship, or the issue, to ways that become manageable. It also serves as a very nice distraction in some cases. This kind of high emotional sensing and a high emotional reactivity person is also quite likely to explore things like self-injury, as a way to shift focus from some distressing idea onto something which is more controllable. And a very good pathway to experience psychosis, at least briefly, is a high level of stress. So people that have high emotional reactivity, who can be flooded with distress, not infrequently will experience brief episodes of psychosis, which probably also revolves around misperceiving the significance of events and trying to come up with explanations between them.
So till now we have, I think, discussed about the manifestations, how they actually manifest in the real life. So if we talk about like what we know, that what actually causes psychosis, right? So how can we explain that what would actually cause psychosis?
Yeah, so there are the really interesting thing about neuroscience, and psychiatry in particular, is that there's many levels of explanation. So I was explaining psychosis, I guess, at a higher level, or a psychological or phenomenological path. So a couple of things to say in terms of more fundamental cause. We talked about the brain being this hyper complex and relatively very fragile organ. So a lot of stuff can disturb it. I talked about acid-base balance or sodium or electrolyte disturbances.
Hmm.
I mean, so any medical illness that changes, say, the energy or electrolyte or acid-base substrate or blood flow substrate of the brain is more than sufficient to cause psychosis in ways that can look indistinguishable from a primary psychiatric illness like schizophrenia. And of course drugs can do this as well. So I have yet. I'm not even. I had the idea one time of making a list of all the drugs that are known to have psychosis as a side effect. I stopped that because essentially any drug can, depending upon
Yep.
the person who's taking it.
Hmm.
So easily more than 100 commonly used medicines, not psychotropic ones, things like aspirin or things like blood pressure medicines, or any of them, are quite capable of causing psychosis in some people who may have other predispositions to it. And by my last count, at least 50 medical diseases can produce that as well. So there's that. Then how do you move from, let's talk about neurotransmitter levels. So many of these disturbances will affect the release of chemicals that the brain uses to communicate or to regulate its
Hmm.
electrical activity. So the brain, again, being a gigantic electrical system designed around a lot of circuits, and these circuits use chemicals to transmit messages from one element to another. So those chemicals, if they are released excessively or deficiently, will disrupt the efficiency of the system. And these other chemicals, neurotransmitter chemicals they're called, can also regulate the gain, so they can make a system more or less responsive as well. So there's many opportunities for chemical signaling errors to change either the outright functioning of a circuit or
Hmm.
to change its gain or its activity or its intensity. And there are a number of neurotransmitters have been implicated. The one that has by far the biggest body of evidence behind it is the dopamine system. Dopamine, I think regardless of educational level, I think most people recognize dopamine, the name dopamine, as a neurotransmitter, and it has a common reputation for relating to pleasure or to attention or to focus. And that begins to speak at its significance of signaling what is important. So again, in this flagging of significance, or this aberrant salience hypothesis that I described, dopamine, you shouldn't be surprised to know, is a key role. It's released when the brain is trying to perceive this is meaningful. That's why pro-dopamine drugs like amphetamine or stimulants are useful in the treatment of ADHD, because they help the brain to generate these dopamine impulses,
Hmm.
which are related to focus, attention, because again, importance. And that's why dopamine is released, or that's why dopamine is implicated in substance use disorders, because again, it flags as important or relevant certain stimuli or experiences related to drug use. And certainly it's involved very heavily in psychosis. We know now I'm going to switch, and we know that it's involved in, let me pause on that one and we'll talk about schizophrenia next, shall we? But let's just say now that people with psychosis with great frequency, not all people with psychosis, but many people with psychosis will have evidence that we can capture in
Hmm.
neurochemical studies or in brain imaging studies of being able to produce more dopamine than average and release more dopamine during chemical impulses than people without psychosis.
Hmm.
We also know that drugs that block the drugs that block the dopamine signal are really good at helping the majority of people with psychosis have less intense symptoms or to negate them entirely.
Hmm. Actually, I have a question here that's very much related to the research experiment we conducted in our undergrad of neuroscience. That was about atypical antipsychotics, but I will ask that at the end when discuss about the further medications. So, from now here, can we say that psychosis is a symptom of schizophrenia, or it's or it's totally different than schizophrenia? If yes, then what actually schizophrenia is? I mean,
Yeah,
if we talk more on that.
sure. Well, yeah, so psychosis is a symptom, and fever is an outstanding analogy for psychosis. Fever has hundreds of causes. I was going to say gazillion, but fever has hundreds of causes, and the experience of fever, the high temperature, and for the subjective experience of feeling hot or of chills, is a facet of inflammation. And psychosis, to reiterate, is a symptom which revolves around misperceptions, but those misperceptions, the clusters of misperceptions, can be generated by lots of different things. So there's that. So psychosis is just a symptom. As I said, it's a symptom of at least 50 different medical diseases and a side effect of 100 different drugs. It's also a symptom that can be associated with conditions which are called primarily psychiatric conditions. So psychosis can be a feature of depression. Psychosis can be a feature of bipolar disorder. Psychosis can be a feature of PTSD. It can be a feature of borderline personality. It can be a feature of drug intoxication or drug withdrawal. And it can also be a feature of schizophrenia. So again, psychosis is just a symptom. But schizophrenia, let's move on to beyond symptoms and now to psychiatric diagnoses. Schizophrenia is a psychiatric diagnosis, which includes psychosis as one of its symptoms. The way that we have decided at this moment in time to organize psychiatric diagnosis is by saying you have to have certain features or criteria for certain durations of time and in certain numbers, and they need to also lead to a distress or functional impairment. So to make a diagnosis of schizophrenia, psychosis is one of the symptoms. You can't really make a diagnosis of schizophrenia in almost any case without having experienced psychosis for about a month, being most of the time, most of the days. So if you have persistent psychosis or regularly recurring psychosis, and that's gone on for at least a month, and that generally there are signs of illness for more than 6 months associated with decline from expected functions, then you possibly have a diagnosis of schizophrenia. But it's also very important. It says it says like category D. Don't make this diagnosis if it's better explained by some other psychiatric condition or by some medical process. So if you can't rule out any other explanation, if you can't find any other explanation, and you have this persisting psychosis associated with decline, then that's what schizophrenia is. So to use medical terms, it's probably more accurate to say it's persistent idiopathic psychosis, meaning that it's psychosis is a prominent or regular feature of this overall disturbance, and that we've looked hard and we can't find any other explanation for it. That said, I don't want people to think that we don't have any idea what causes schizophrenia, because we actually have a lot of really good leads. If we simply look at what medication responses tell us, then we can say that in 70% of people with schizophrenia, we should probably call this dopamine psychosis. In other words, about 70% of people with schizophrenia will have a very good clinical response to just simply reducing the dopamine signal. And about 30%, I would call them, 30% of people with schizophrenia have an entirely different set of diseases that appear to have nothing to do with dopamine. So I call that the dopamine irrelevant subtype.
So as you said that we have a lot of things to discuss on what causes schizophrenia. So let's move towards that point. Like people would be very curious to know that what actually causes schizophrenia.
Well, that is the billion-dollar question. I think to get to say a 5-sentence explanation of cause, we're not there yet. But we do. I'll tell you what we do know. That there seems to be a genetic predisposition. So one may inherit a set, one or more genes that have a variety of different functions, but seem to set up during either intrauterine or early life development, a brain which might be prone to reacting badly to certain kinds of environmental stresses. So, and then when you have these environmental stresses, and or as the brain begins to further develop and mature itself into a late adolescence or early adulthood, this vulnerability to misperceptions will unmask itself. Speaking of, since I mentioned genes, I just want to say that at last count, there were 109 genes that are associated with schizophrenia risk. This set of genes goes by the name polygene, or the schizophrenia polygene, and it's fashionable to in some research settings to try to do genetic analyses and tally up how many of these risk genes a person has and call that the polygenetic risk score. The practical or clinical significance of that remains to be determined, but I want to just make the point that it's not one gene, it's not two genes. There are a lot of genes that are conferring schizophrenia risk. And also on the topic of genetics, I want to point out that of those 109 genes, a lot of them are also risk genes for major depressive disorder, and a lot of them are also risk genes for bipolar disorder. So it leads some people to wonder if we inherit a genetic or developmental predisposition to some kind of psychiatric symptoms later in life, and that it is environment plus psychology that determines if I will develop a depressive syndrome or a bipolar syndrome or something that we call schizophrenia. It's a very attractive. It's an attractive idea because it can explain why a drug designed to block dopamine receptors and treat schizophrenia is also useful in the treatment of bipolar mania, and is also useful to make antidepressant medicines be more effective for people with depression. So it can, that can explain the pharmacological overlap that we see between these three diseases, and also why we see in families with multiple generations of people with mental illness, you will see some examples of depression, some examples of bipolar, and some examples of schizophrenia. So it's I think remains to be proven, but I think it's very attractive to view that we carry certain vulnerabilities, and that psychological factors plus environmental stressors will shape how they're expressed if we are unfortunate enough to have them expressed as a psychiatric syndrome.
That's wonderful. So I'll discuss one point from my the paper that I wrote in my final year, and so I want you to talk about that, because that would be really interesting. Because I wrote that atypical antipsychotics would show response with firing the action potential and without binding with the postsynaptic membrane. So, like the difference, would you tell our audience the difference between the typical and atypical antipsychotics, and are there any more side effects for typical antipsychotics rather than atypical antipsychotics, which have much of the motor coordination impairments, maybe?
Sure. So it's a good question, and I tend to go back to history to help understand how things unfold. So let's start the story in the 1940s. There were pharmacologists had discovered molecules that block the histamine receptor. So we had, for anybody who suffers allergies is grateful for the discovery of drugs that block histamine receptors. And it was a very exciting discovery. These antihistamine drugs tend to be relatively, especially the first generation of them, tended to be relatively sedating. They also had a tendency to reduce, to dry a person up, to reduce secretions. And they thus, surgeons thought that those qualities of having a mild sedation as well as an ability to reduce secretions might make very useful drugs for somebody who is about to undergo surgery. So it was a surgical team that were looking for essentially better antihistamines. They discovered one that they got the name chlorpromazine, and when tested in surgical patients, it had a lot of really sort of outstanding calming qualities that staff had observed, and so the idea was that that might be useful for people with severe mental illness if you have something that it can be relaxing or calming. So chlorpromazine was then moved from surgical testing to psychiatric testing and found to have a very surprising and an enormously effective benefit for people with psychotic disorders. So it became the first antipsychotic drug. Again, interestingly, it was designed as a histamine antagonist. So the initial thought was, if we develop more antihistamines, we will solve the problem of schizophrenia. Turned out that it was actually the dopamine antagonism, which was not intended, that turned out to be the useful quality. So once pharmacologists deduced that it was the dopamine antagonism that was the beneficial action of chlorpromazine at treating people with psychosis, then every pharmaceutical company on the planet was developing dopamine receptor antagonists. So we had this explosion of drugs which are designed to be dopamine receptor blockers. And I'm going to be a little bit facetious here, but it's difficult. They are so reliably effective at reducing psychosis that I think almost anything that blocks dopamine is a candidate for being an antipsychotic drug. But if you do that, if you do just that, you do get a fairly good response in psychosis. As I said earlier, drug response data suggests that about 70% of people with psychosis have a dopamine excess signaling issue, and using the right amount of dopamine blocking can be a great solution for that. If it's too much, then you wind up with a whole bunch of problems, what I'll talk about in a second. But that's great. So when you block too much dopamine, you wind up with a bunch of symptoms that look like Parkinson's disease. We call this, in fact, drug-induced Parkinsonism. Yep. So you get a tremor, you get a general slowing down of activity, you have reduced facial expressions. Subjective experience of that is reduced interest or enthusiasm, sort of like a big wet blanket. And so that's we'll call those motor symptoms, or they also go by the name of extrapyramidal side effect. And that's the biggest liability. In addition to those, you have another problem of developing unusually stiff or cramped muscles. And you can also develop a sense of intense restlessness. So all of those are the, if you will, the motor side effects or the neurological side effects of any drug that blocks dopamine receptors, including a lot of older anti-nausea medicines. Then along came a drug which was named clozapine. And when I think it was Seebeg, I don't want to say something wrong, but the company that was making it was, by the time the clozapine came around, it was really simple. Get the new drug, give it to a rat. If the rat freezes, if you compose it like a statue, in other words, if you can give the rat Parkinsonism, then that drug, we can move it forward to test further as an antipsychotic drug. So when clozapine was evolved from that laboratory, they gave it to rats, and they thought at first, this is a useless drug because it didn't cause rat Parkinson's disease. But miraculously, it actually made it into clinical use, and it turned out to be probably the best treatment for schizophrenia ever. To this day, clozapine is hands down the most effective drug for schizophrenia, all things considered. That's a loaded statement, so I want to qualify in the grand consideration of things. Clozapine is probably the best drug for schizophrenia. There are exceptions to that. But coming back to, then the race was on to figure out what special things clozapine is doing so that we can copy that into a new generation or a second generation of drugs, which are not just geared toward being dopamine antagonists. So to your question, typical and atypical is kind of synonymous with first generation focusing exclusively on dopamine receptor, and second generation modeled after clozapine, which the secret sauce turns out to be blocking serotonin receptors. So the second generation drugs are, broadly speaking, dopamine plus serotonin antagonists. And when you do the serotonin antagonism, then you wind up with a greatly reduced risk of motor side effects.
Mm-hmm.
So you have less likelihood of tremor, less likelihood of muscle cramps,
Mm-hmm.
less likelihood of these sorts of things. So they got the name of, they also get the name, in addition to second generation, the synonym is atypical, because it was thought that the typical drug, aka first generation, produces these motor side effects, and atypical drugs, the pharmaceutical companies would have had us believe, don't. The fact is that the second generation drugs, we can fairly say, are less likely to produce them, but the risk is not zero at all. And in fact, if you do my work long enough, you will see that no matter what the second generation drug, you can still find people that have those motor side effects from them. Although, to be fair, it's less frequent. What you do get with second generation or so-called atypical drugs is a concerning and inadequately explained tendency to gain a lot of weight, to change energy metabolism. And as I said, inadequately explained, because no one explanation actually accounts for the whole spectrum of observations. Some theories would have us say that they increase the appetite, which you can get when you block serotonin. You can get when you block dopamine. You can get from blocking serotonin. You can get it from blocking histamine. They interfere with satiety signals in the brain, and they may, by mechanisms not well understood currently, directly impact the insulin responsiveness of cells. So it's a trade-off, and what's better for a particular person is debatable and should be determined by that particular person. But you have less neurological side effects, but on average, you have a higher risk of the so-called metabolic side effects from those drugs.
That's actually wonderful, and even I got a very wonderful explanation. Even I did my whole research paper on that, but that was something confusing because there was not much research on that specific topic, because it was mostly like just it was industrialized, right? So it was just like initial theories and hypotheses. So it wasn't even clear at that time, but it very much clears now, because I remember we gave amphetamine intraperitoneal injection and plus antipsychotics, and one group of Vista rats. Yeah, we gave them saline solution for the control group. And so as you said that we also conducted, like I remember, the social interaction test, right, and the motility test to check that how they interact with different solutions we inject them. So I have one more question that would specifically target the neuroscience, but before that, I want to ask about the symptoms of schizophrenia. How can we describe the symptoms of schizophrenia?
Yeah, so there are the syndrome of schizophrenia. There are 3 clusters of symptoms, and I want to make clear before I forget, which I might do at the end. I want to make clear at the beginning. I'm going to describe a set of different clusters of symptoms, but one person with schizophrenia may only have one set of symptoms. So although I'll say that there are a cluster of cognitive symptoms, many people with schizophrenia actually have very good intellects, and many people with schizophrenia. So it's not obligatory that they all have all of this. This is just, as a large group of people, and people with schizophrenia are a diverse group of people, you can see any of the following. So clusters of symptoms, broadly speaking, are so-called positive symptoms, negative symptoms, and cognitive symptoms. Positive, we get that word because we get this word from older days of thinking about schizophrenia. And part of me wants to just, in fact, I'm going to digress. But I'm going to come back to positive, negative, and cognitive symptoms. But since I brought up the topic of terms that were generated in old days, I want to say here that schizophrenia is such an example. It was coined in about 1920 in an era which was dominated by Freudian psychoanalysis, and which was devoid of any modern understanding of psychology or neurochemistry. So schizophrenia means split mind or split head. there is no split involved in schizophrenia, and there is no head. So this name is anatomically and scientifically inaccurate, and it is brutally stigmatizing, and it needs to just be retired and put on the ash heap. In Japan, they've actually renamed it, and they call it integration disorder, which I think is a brilliant name because it gets to a primary process. We talked about you have integrating sensory information, forming perceptions, and integrating those perceptions into a meaning. Those processes of primary integration or secondary integration are the things which are disrupted. So integration disorder would be a, incomplete but much closer to accurate description. Schizophrenia, it needs to go. We'll talk about it because that's the coin of the realm term, but it is really, and to my way of understanding, it is, to listen to people that have it is a stigmatizing and offensive term. And I think that we deserve to give patients and families and us the benefit of terms that more accurately reflect illness, because it's the right thing to do. Okay, so back to those older days, though, in the syndrome of schizophrenia, what were called positive symptoms were like added. So these are things that don't normally exist in ordinary experience, and so thus positive. So the delusions, the hallucinations, and the consequences of those, which are disorganized future behavior. Those are things which are like usually easy to see and perceive. Those are positive. Another cluster of symptoms is called negative, reflecting the idea that these are things that normally should be there that tend not to be there. And those are things like animation, like enthusiasm, like inflection of tone in speaking, like impulse to have social relationships and activities. The syndrome of negative symptoms are kind of the opposite of that. People with schizophrenia, on average, may experience decreased enthusiasm, decreased energy, decreased motivation, decreased vibrancy of emotional experience, and so forth. And since I'm on this topic, I also want to point out to anybody listening that a lot within the secondary symptoms, some of those probably are due to inadequate activation of certain areas in the brain that serve those functions, but they're also identical to side effects of antipsychotic drugs given at too high of a dose. When that happens, we call them secondary negative symptoms. And so it is when a clinician is faced with somebody who has a lot of negative symptoms, my first recommendation is to review the dosing of medicine and to try to make sure that we are not excessively dosing the person, because there are so many examples that I've seen in my practice and my practice, which is a consulting practice, so I usually get cases like, I have this patient with so many negative symptoms, what do I do? And so when we walk down the dose of the medication, the reports are glowing. It's like, I can't believe how good my client is. They now are still without psychosis, but now they have energy. Now they have, so I mean, we in my field, well, let me go back to chlorpromazine. We had chlorpromazine, had no idea even what it was for. I mean, we didn't know what patients of all those in the hospitals are most likely to benefit from it. And when we did figure that out, we didn't know how to dose it. So we had a tendency to overdose the medicine. And then we basically thought, well, the politicians thought, oh, we've solved mental illness. We can close those long-term hospitals and we can take care of people in the community. Sad thing is they didn't give the funding or the resources to build that network of support. So then the profession largely relied on overdosing medicine again. So we over-relied on medicine to try to do things that medicine was never intended to do. And when clinicians do that, they tend, again, to overdose, like doses are too high or have too many medicines. So like for the first generation, when we had patients in hospitals, we simply didn't know how to use the medicine. And then in the deinstitutionalization area, we over-relied on medicine. So really up until for most of the history of pharmacotherapy of schizophrenia, we had misguided notions about what effective doses are. Now, using brain imaging studies where we can actually visualize the occupancy of dopamine receptors in vivo, we have a pretty good idea of what the sweet spot is, and the doses required to achieve that are lower than many people imagine. So to come back to negative symptoms, it is a primary syndrome of the illness itself. It's also, unfortunately, can be a side effect of over reliance and overdosing in medicine. And then, so we talked about positive symptoms, negative symptoms, and the third set are a very broad set known as cognitive symptoms. And again, not everybody has all these symptoms, and even within cognitive symptoms, not everybody has all those, but it's not uncommon to see people with schizophrenia have difficulties with attention and concentration, or with short-term memory, or with complex problem solving, or with hand-eye coordination. So the fact that you have a spectrum of neuropsychological abnormalities, again, probably reflects the fact that the brain is either miswired itself or is not firing in adequate ways to serve these the substrates that execute those functions. But again, not everybody has all of those. We do know that if we do cognitive testing and we give a person a full panel of neuropsychological tests, and we identify which specific subsets of cognition are impaired, we can then brilliantly move them to largely computer-operated games or tests to enhance it. So imagine that I have a difficulty with short-term memory. I can actually train my memory using largely like drill and practice exercises with computers. And data are really, really compelling that if I do what's called neurocognitive remediation, and pair that with experiences in the world to sort of employ that can have a really amazing impact on quality of life and function. So one of the bright spots for the future of schizophrenia care is beginning to tap into cognitive remediation strategies and pair them with environmental real life situations to deploy them. And the benefits are tremendous from that. So if we can, to just now segue to some reasons to be very optimistic about the future of neuroscience in this area, if we can identify people at the earliest stages of psychotic illness, get them the right medical evaluation to determine the cause, and when it looks like schizophrenia is the diagnosis that fits it, then intervene early, not just in giving them the right dose of medicine, but also addressing the psychological factors that are related to this, supporting the family, getting them back into school or work, and so on, and pair that with things like cognitive remediation. This is a set of game-changing interventions that will show us just how badly we've misunderstood this illness for the last 100 years.
So, as you talked about about the brain images, that we can target certain areas, that because with the brain images you can do that, right? So, there's a question what specific pathways in the brain are targeted, and where exactly the dopamine receptors in the specific pathway of the brain they are targeted,
So here's I just want to thank you for that question, and I want to, as a pharmacologist, as a card-carrying pharmacologist, and one who, I say tongue-in-cheek, love drugs, I want to point out drugs don't know anything. Drugs are useful tools, but they're kind of indiscriminate tools. You put a drug in the body, and it will diffuse to wherever it gets access to. And most of the psychotropic medications are designed to be very lipid soluble so they can cross the blood-brain barrier. So once there, they have free reign. So to put a drug into a body, it will go everywhere in the body, anywhere that it possibly can. So drugs they're indiscriminate tools. So the brain, to your question of where dopamine receptors are, there are clusters of dopamine neurons and receptors scattered throughout the brain, some areas denser than others. All of those areas are going to be bound to the drug. which can then give you the beneficial effects. For example, if they block the signal of dopamine in what's called the mesolimbic pathway,
Yep.
you can wind up
Mhm.
probably, that's probably the site where you have antipsychotic or positive symptom reduction, but they will also block the dopamine receptors that exist in the frontal cortex. And when that happens, you invite the side effect of cognitive impairment and lack of enthusiasm.
Mhm.
So we can, we can certainly make very good speculations and very probably accurate speculations about regions of the brain in which drug actions are relevant to the therapeutic effect, but we can in no way currently tell the drugs just go to that space and do that one thing. So they like blanket the whole system, and so that's why, as a pharmacologist and one who uses drugs helpfully,
Mhm.
I also want people to understand you need to use them judiciously, because they don't know where to go, and they
Mhm.
will we need to respect the fact that they always have side effect possibilities.
Mhm. So, as you said that once they cross the blood-brain barrier, they can go anywhere, right? But aren't they much more specific to nucleus accumbens and ventral striatum, that specific area where where there's hyperactivity of maybe dopamine, or where they specifically block that, or it isn't specific to those areas?
No, I mean, if you put an animal or a human into a scanning device and try to
Mhm.
see where the drug is bound, you'll see
Mhm.
higher signals in those areas because the dopamine receptors are more dense in those areas, and they usually calibrate their returns so that you show brightness. And in other areas where there still are dopamine receptors but less dense, they will
Mhm.
show up as blank. But they're still, so they are indiscriminate. They just show up as, they show up brighter on PET scans because the density
Mhm.
is higher in those areas.
So there's no way till yet that we can control their activity in the other parts of the brain. Let's say they move towards the frontal cortex, right? In the prefrontal cortical area. So they would be also impairing the behavior, thinking, and all these tips, because your critical thinking, behavior, and decision making, they're all traits from the prefrontal cortex, right? So there's no way till yet that we can control their movement there.
No,
So
no.
there would be definitely side effects with the with the medicines used in schizophrenia, with the other parts of the brain.
Yeah, exactly. There's no, I mean, there is in our universe something, they're the saying, there's no free lunch. You don't pour, you don't get something for nothing.
Mhm.
Which is again why, as a person who as a pharmacologist and as a psychiatrist and a person who cares about the well-being of people that are suffering, um, I want everybody to know that drugs don't know where to go. This means that every single prescription comes with it
Mhm.
a large number of possible risks. And now I'm going to get a little bit editorial or preachy. Again, what I primarily do, what I've done, well, when you get a PhD in pharmacology and you go into psychiatry, immediately people give you all the hard cases. So it's like, I haven't, please see my person. So I wound up, I just defaulted into a career where I just get people who have had complicated courses of illness,
Mhm.
complicated treatment histories, and have not gotten a lot of benefits or have
Mhm.
gotten a lot of harm. So my view of the world is was a lot skewed from seeing this population of casualties.
Mhm.
Um, but some common themes in my work are that patients will say, this drug makes me feel, let's say something simple like antidepressant medication. So I'm taking an SSRI medication,
Mhm.
um, and the book says it should help with depression and anxiety. That's what I have, but I just feel depressed, and I feel more depressed now than ever. So then what will happen is that the doctor will prescribe more of that medicine, or use another medicine in the same class or whatever. But the patient will keep saying, I feel worse. I think this is making me worse, they will say. But because physicians aren't generally trained to think about like basically anybody can get any side effect from any medicine, then at least in the patients that I see, no, you need more than medicine. So the idea is that the idea that maybe this medicine is harming you and making your depression worse doesn't enter the mind of some prescribers because they're supposed to make it better. But if you go and look to the other thing that happened as a PhD is I learned how to access medical literature, and I read that like as if I read that like candy every day. So pro tip, if you want to be a master psychopharmacologist, go read PubMed every day about any problem that your patient has, and then you'll probably find there's a bunch of stuff you didn't know. So if you go to medical literature, it's really, if you simply search SSRI anhedonia, you'll find all sorts of papers that say that between 10% to 30% of people on SSRI medications experience significant apathy or anhedonia. So so in this hypothetical example, based upon real life experience, if this person who was telling their first doctor, I think I'm worse because of this, had been heard, I never would have seen the case. So, but to come back to the point, drugs are indiscriminate. They go all over the place, and we need to respect the possibility that statistically, we can cause our patients with illness to get a lot better life. It is possible to find the right medicine for the right person and have either no side effects or minimal side effects. That happens all the time. But we also, at the same time, need to understand that, as I say, anybody can experience any side effect from any medicine. And particularly to the point of dopamine receptor blockers, at the right dose, it is possible to eliminate the symptoms of psychosis. And with that gone, a person can think better, function better, and engineer a life which is functional and high quality. However, it is possible that if we, that the person might be sensitive to frontal cortex blockade, or that we've chosen a dose which is too high and then does this, and it creates a syndrome of apathy, anhedonia, cognitive impairments. All these things are listed, all these things are described in medical literature as known possible consequences of these medicines. The art of medicine is to, listen carefully, know what is possible in the realm of side effect, and then to choose the right medicine for the right person and give it the right dose to minimize that.
Because I remember, in my country, in Pakistan, it's very common to prescribe SSRIs and benzodiazepine. Because my mother recently, when you just named it SSRI, I remember my mother. She just had an appointment with the doctor, and he gave her the SSRIs. And actually, because it's different when you're into the research, you study the, as you said, that you need to study PubMed and all that articles, because you study totally the different route of that. So considering SSRIs, are there many side effects of that as well?
Do SSRI medications have many side effects? Yeah, they do. Of course they do. Everything has side effects, and they're listed in the. Also, we'll call this pro tip for people who want to prescribe. I encourage anybody to let's say, type in name of medicine. We'll say fluoxetine as an SSRI. So these days you simply go to Google, type fluoxetine prescribing information, or insert drug here, prescribing information. You'll wind up with a hit on page 1 that says access FDA blah blah blah. It's the FDA website where they have prescribing information for all drugs that are approved in the United States. The prescribing information should always be read before anybody prescribes any medicine. And ideally, not everybody has a technical ability to read it, but ideally the patient will read this as well, or have a good summary of it, because the manufacturer is required to do tests against a placebo and list the adverse effects that occur. So you see the likelihood of people in the treatment group versus the placebo group. Also, drugs are required to have post-market surveillance. And so for older drugs like fluoxetine, there is a body of post-marketing surveillance data that eventually gets incorporated into the prescribing information document. So So go to them all and you will not be surprised. So yeah, SSRIs have a ton of side effects. The one that is the far and away most common, least talked about, and as awful as anything else, is an ability to impair sexual function.
Mm-hmm.
They most commonly reduce the ability of a person to achieve orgasm,
Mm-hmm.
and relatively commonly, a bit less commonly, but still very common, reduce sexual interest. So they decrease
Mm-hmm.
libido, or they decrease ability to achieve satisfaction. So now
Mm-hmm.
let's imagine that you're a person who's depressed, and let's do two scenarios. You're a person in a relationship who is depressed,
Mm-hmm.
and relationships are extremely important for human well-being. We
Mm-hmm.
are social animals and require relationships to function. You're now in
Mm-hmm.
an intimate relationship with a spouse, and you take a medicine which makes you not interested in sex or not able to get sexual satisfaction. That has a profound effect on your relationship, which is a profound effect of your support. So if you have given a medicine, if you're taking a medicine which is now disrupting the underlying nature of one of your most important relationships, how can that not be a significant risk against getting better from depression? Let's imagine now that you're a person that lives alone, and people masturbate. Almost everybody does. The data say that more than 90% of men and women, probably as 98%, masturbate regularly. And for many people with depression, self-sex is like one of the few satisfactions they have left. And now you give a drug which takes that away? Seriously? So the sad fact, so I've been doing this long enough to see how things work in terms of medicine and marketing.
Mm-hmm.
The sexual side, because people don't talk about sex, it probably wasn't reported at its true frequency when it was undergoing pre-market clinical research. And once it was on the market, it was seen as an unlikely side effect, or like maybe 10%. 50% of people that take SSRIs experience that side effect. It's a gigantic
Yeah,
problem.
that's true. That's a
Um,
gigantic.
so, but they have many other. They all do. They all do. It's important. Drugs can be fabulous tools,
Mm-hmm.
but they can also be fabulous poisons. And
Mm-hmm.
so, a good physician will appreciate that all the time, and have a lot of worry about whether, a good clinician will always want to know that things are working, and will be really strongly inviting the report about intolerance or side effects, because we're in this business to try to help people improve their life quality, not to give them these debatable bargains of, I get a little bit better in my mood, but now I have to deal with X, Y, and Z all the time.
Mm-hmm. Wonderful. So coming back to schizophrenia, that there are two questions. How schizophrenia can be treated, and what if someone isn't like cooperating with the treatment, or they aren't responding to the treatment? I would say not cooperating, how they're not responding to the treatment. So what to do in that case?
So the treatment for schizophrenia, let's start off with saying that, again, schizophrenia is a condition which you can think of as a illness, like a longer term illness, characterized by frequent episodes or prolonged episodes of psychosis,
Mm-hmm.
which, as we've also said, may go along with social withdrawal,
Mm-hmm.
and with some impairment in ability to think as well as one used to.
Mm-hmm.
Um, it impacts, if you will say, every area of life. And so if you have a condition which affects so many facets of living, treatment for schizophrenia, I want to make this point, pounding the table, treatment for schizophrenia to be fully successful needs to address all the facets of illness that are impacting life quality. Typically, we think medicines, but it is very important. It's very helpful. It's very helpful and very important that people with schizophrenia get very good psychological support, both in terms of having somebody that talks to them as a human being, connects them to the world that is familiar, lets them know that there is hope they are valued. This is, of all the people, I get to meet a lot of people who have had full recoveries from schizophrenia. That is the common theme amongst all highly successful schizophrenia recovery stories, is that connection that was meaningful, hopeful, and saw them through the difficulties of high levels of symptoms. It's also very, very helpful and fully evidence-based that psychological therapies which help you to understand how symptoms are happening and relate to them differently in ways that say, like, to avoid saying my brain is broken, my life is screwed, rather to sort of relate to the experiences in ways that are less judgmental, less fear-provoking, can themselves reduce stress, and stress also impacts illness severity. Having somebody with schizophrenia affects their relationships. Friends and family don't know what to do or how to respond. So teaching friends and family about the nature of the illness and how to be helpful is also helpful. Having them connected with somebody to improve or help solve day-to-day problems in terms of getting back to work, getting back to school, how to navigate relationships, also helpful. So a lot of schizophrenia treatment is at best incomplete and may actually be ineffective unless we pay attention to all these extremely important non-pharmacological variables. So I want to say that because we live in a society that overvalues drugs, and so when a psychiatrist talks about medicine, we think, oh, that's the answer. So I want to lead with, it is a part of an answer that will likely not succeed in the long term unless it is paired with other things. In general, I say that psychotropic medications are very much like bicycles. They help a person move. They help a person move from where they are to where they want to be, but they usually don't do it all by itself. It makes the work easier and more effective. So antipsychotic drugs can reduce usually the positive symptoms of schizophrenia by reducing the strength of the dopamine signal. So we know from a lot of studies, let's go back to dopamine and brain scanning. Using positron emission tomography, there are techniques that allow us to measure the ability of the brain to synthesize dopamine, and there are ways to estimate the amount of dopamine being released. And there are other techniques which allow us to look at the receptor side after it's released. So there's a very, very clear signal that the majority of people that have schizophrenia have increased ability to make dopamine, and they release more dopamine per impulse. So it's on the presynaptic or postsynaptic side, schizophrenia is a presynaptic hyperdopaminergic syndrome for the majority of cases. So it's helpful to reduce that signal, but not to negate that signal. So using the right dose of a dopamine receptor antagonist is the default strategy as a first-line strategy for people. It's the first-line pharmacotherapy strategy for people with schizophrenia. Usually it works. If it doesn't work, then you have a condition that gets the very poorly chosen name, treatment-resistant or treatment-refractory schizophrenia. Looking at existing current data, it's probably more fair to say it is dopamine-irrelevant schizophrenia or normal dopamine schizophrenia or normal dopamine psychosis. In other words, the schizophrenia that doesn't get better in response to dopamine receptor antagonists means that it's a non-dopamine illness. So I like to say as a pharmacologist that drugs are cool because they tell you the truth. They investigate physiology. If you learn to read drug response as reading tea leaves or as like trying to decipher the report from some distant land, you will learn a lot about how bodies work and about how illness progresses. So drugs are like touchstones to physiological reality. So when you give repeated attempts of dopamine receptor blocking and they don't get better, then what you're looking at is really not a dopamine illness. So that's what so-called treatment-resistant schizophrenia is. So to your second question, how to respond when people aren't getting better from treatment, there are, generally speaking, three factors to consider. Factor one is that your diagnosis is wrong. So that you have diagnosed somebody with schizophrenia, you're treating them as if they have schizophrenia, but in reality, they have, let's say, a meningioma of their frontal lobe. One reason why people don't get better to treatments designed for schizophrenia is because it's not schizophrenia to begin with. In my view of the world, and actually not just me, reading reports upon the prevalence of unrecognized medical illness amongst people with schizophrenia, I can tell you that the risk is between 5% to 20% that person that's not responding to medicine has a medical disease that's the cause of their illness, not a psychiatric illness. So wrong diagnosis is one. Thus, when a person is not responding, the clinician needs to go back and make sure that there's not some occult medical illness is really causing symptoms. Second approach to treatment resistance or treatment non-response is maybe there's something else really important happening that I didn't know about. So maybe my patient is using stimulants without telling me, or maybe my patient is using cannabis without telling me. By the way, cannabis is well known to exacerbate psychosis, if not outright cause it, and it's oftentimes overlooked. Or we also know that stress causes or worsens schizophrenia. So in other words, there might be other medicines or supplements or drugs or family dynamics or social dynamics which are exacerbating symptoms of illness. So I need to look for those sorts of causes. So we said, look for another diagnosis, look for exacerbating factors, and then finally, look for something that look for a drug that does something different than recreate the mechanism of action of the drug that's already failed. So to simplify it, if you come to me with a cough and a fever and I give you penicillin and you still have a cough and a fever, and then I give you amoxicillin and you still have a cough and a fever, this is nature's way of telling me you do not have a gram-positive infection. So giving another medicine that also is targeted for gram-positive bacteria is designed to fail. So to make it in schizophrenia realm, if I've given you 2 rounds of dopamine-blocking drugs and you're still not better, then there's stuff other than dopamine which is relevant to why you're seeing me. So what other drugs to use? Well, it goes beyond the scope of this conversation, but there are at least 40 of them that tap into mechanisms of action other than dopamine receptor blocking. But all things considered, the odds very strongly favor a medicine called clozapine. Clozapine, the one I mentioned about earlier, the very first atypical drug, when it was tested in animals, had no signal that it was a dopamine receptor blocker. It does a little bit, it's very weak, but it clearly has other things behind it that are more important than dopamine. And in fact, so think of clozapine as a non-dopaminergic drug. And if you look at this population, at least 30% of people with schizophrenia that have this condition, poorly chosen name, treatment-resistant schizophrenia, non-dopamine schizophrenia, 50%, one half of them, will find the clozapine is both tolerated in terms of side effects as well as effective. It's a no-brainer choice, but you might detect my voice is getting a little more impassioned. I am because in the United States, only 4% of people with schizophrenia have clozapine in their treatment. If we think that 30% of people with schizophrenia have this disease entity that responds in 50% of cases to clozapine, then we should have at least 15% of people with schizophrenia in the US on clozapine. If you look to any country in Europe or Australia or China, you'll find that between 20 and 30% of people with schizophrenia are on clozapine. So the real world data says that we ought to, if we adhere to simple treatment algorithms that are designed on evidence, that we ought to have 15 to 20% of people with schizophrenia in the United States on clozapine. We have 4% of our patients with schizophrenia on that drug. And clozapine is the only drug that the FDA has recognized as having an ability to reduce suicide. And people with schizophrenia 50% of people with schizophrenia attempt suicide and 10% die by suicide. So the fact that we have 4% of people with schizophrenia on clozapine, we ought to have 20, means that 16% of the 3 million people in America with schizophrenia are at risk of suicide, which could be prevented by simply giving them the right medicine. So to the question, what do? You try to get them clozapine and expect a 50% response rate. And by the way, when people respond to clozapine, it's oftentimes much bigger and better response than you get from other drugs. And for the 15% of that group that don't respond to clozapine, then call me, and we can look at the other 40 options. I mean, there's no end to options to help people with schizophrenia achieve much higher levels of recovery. Oftentimes, full recovery is a realistic goal. It's weird to hear people say that because for 100 years we've really aimed low, but it certainly is, with our current understanding, recovery is a realistic goal that everybody should shoot for.
Wonderful facts and explanation. So my last question would be, what would be your message or suggestions for people suffering from schizophrenia or psychosis, and to the people around them?
Yeah. So the first thing I want to say is that if you have psychosis or think you have psychosis, or if you're a family member of somebody that you think has psychosis, number one, you're in good company. 1 out of 10 people will experience psychosis at some point in your life. So I say this because it's felt as an alienating experience, but it's really actually very common. It's just nobody talks about it. It's also, keep in mind, psychosis is a symptom which tells us that the brain has begun to process information inefficiently. It's generating misperceptions of sensation or significance, and the mind is trying to connect these things is trying to make sense of things that are essentially misperceptions due to information processing difficulties. So we have medical tests that we can do to try to detect any of the 50 different medical diseases that can cause psychosis. We know of 100 or so medicines that can do that. And if it turns out to be related to a psychiatric condition, we have very good treatments for all these things. So the second thing is that people with psychosis recover from psychosis. So I would encourage anybody who knows somebody with psychosis to call and try to get assessment and try to figure out what the cause is, so that then they can get treatment. And in many cases, it's fully realistic to expect that the psychosis can go away. In other cases, it's fully realistic to expect that the psychosis severity will go down to a point which makes it possible to function and have a high quality life anyway. And in the tiny handful of cases where psychosis can't be gotten significantly better, it is certainly possible to reduce the stress and to find other ways to make life good and enjoyable. So it's because we have attached this word to pejorative adjectives like psychotic or synonyms for crazy and all this stuff, it has a lot of fear attached to it, a stigma and predictions of pessimism. But in reality, we can do a lot with good analysis and good treatment to find the cause and to get it into remission.
Wonderful.
Oh, and then the second thing I want to reemphasize, thank you, is that amongst people that have schizophrenia, I meet so many patients and families that have said along the lines of, I'm doing so well, or my loved one is doing finally so much better. He or she is able to go back to school, to have relationships and all these things. But they express frustration that it took them 4 years, 5 years, 9 years to find that clozapine was a helpful medicine. So, if the data say that 70% of people who are given the right dose of the right medicine will get better from the first medicine. For the handful that don't, we can get them better with clozapine, and we can dose it in ways that will minimize side effect risk and maximize recovery opportunity. So it seems to me there's such lack of awareness about clozapine as such a very good option that I want anybody who knows of somebody with schizophrenia who's not getting the results that they desire to ask the treatment provider, has clozapine been considered? And if not, then start learning about that medicine and considering it. And to that end, I, along with folks at my university, have created a website called clozapine.info. Clozapine, CLOZAPINE.info. It basically is a concise guide to what clozapine is and does, and if there are any clinicians who want to learn about clozapine prescribing, Clozapine Info will have information about how to sign up for a quarterly training that I give for people who want to learn more about this medicine and prescribing it. So, to your question about what's useful, from what I hear from families, that's like a secret knowledge that a lot of them wish they had known earlier.
Great. So I must say that was the most lengthiest podcast I ever had, and it was wonderful because it was the first podcast I actually had that was regarding my own field, and it was really fun and a lot of learning from you. And I really thank you for joining me today on the podcast, because I think that many of my friends who are doctors, young doctors, they would, and psychiatry aspirants, they would learn a lot from this conversation. And thank you so much for giving us so much knowledge on this certain topic and for your time. Thank you.
And my pleasure. Thank you.